All right, guys, chapter 43, Pediatric Emergencies. Just so you know, hopefully you've already taken a look at this material, but this is a lot of material. So this is going to be several videos and quite a bit of talking and quite a bit of words. But somewhere in the neighborhood of 200 and something slides, I think 290 if I remember right, as well as just a lot of information. So when we talk about testing, you know, we looked at 41, 42, and 43. 41 was obstetrics, 42 is neonate, 43 is pediatrics. This will make up, I shouldn't say the bulk of the test, but probably at least 50% of the test, and maybe even 60% of the test. So pediatrics is going to be very important moving forward. There's so much information here that you know, we're gonna be covering a lot. So getting into it, introduction. So children differ from adults in their anatomy, physiology, emotions, experience a range of illnesses and injuries. So, you know, they're just small people or just small adults. That approach is not going to work very well here because their anatomy and physiology is so different. Also the way that they process things, obviously. So children, you know, they perceive their illnesses or injuries differently than adults. Young ones may not be able to report what is bothering them. Fear or pain, as you can imagine, can hamper the assessment. Stressed or frightened parents and caregivers may also pose challenges when we're getting information or going to the ER or whatever. And then your personal approach to pediatric patients must be based on their age and accommodate their unique developmental and social skills. So we're going to go into a couple of groups here. Neonate and infant, by definition, neonate is that first month. Infancy is that first 12 months. You can see a lot of different infant development pieces here, bullet points, but the thing is, you know, I mean, make sure you sift through that and take a look at everything through physical, cognitive, emotional. But one of the things we need to remember is that we need to respect the caregiver's perception that something is wrong. So, you know, if you've had a small child, you know that things, a lot of times when they're sick or hurt, things just don't make sense. And you may potentially overreact, and so do lots of other moms and dads. So, you know, remember that emergency, that word is different for nearly all of us. You and I's particular opinion of what an emergency is going to be a whole lot different than someone that's not been exposed to what we have. So the thing you want to look for when we talk about these kids, watch for persistent crying, irritability, and lack of eye contact. Now, these kind of things can be a symptom of some serious problems. So bacterial infections, cardiac problems, depressed mental status, electrolyte disturbances, all very serious issues. Also, nonspecific concerns about behavior, feeding, sleeping pattern, arousability. These all can indicate a serious underlying illness. As you can imagine, increased mobility can lead to injury. So the more they're up and moving and picking up things, the more injuries typically that come along with these little guys and gals. But also with kind of some weird things. So developmentally, what you kind of expect out of, say, a 1-year-old, if they have some kind of injury that doesn't really match up with that developmental stage of like if somebody said the 6-month-old pulled the frying pan off of the stove and hit themselves in the head with it, that should alert you that that probably didn't happen and that we might want to start thinking about some possible abuse. So during our assessment, keep the child warm. You see all of our bullet points here. Some of the considerations: we need to choose the best location, keep them warm, support a young infant's head and neck. Remember, they haven't built up all those neck muscles yet, and their head is very heavy for them. Older infants in stable condition will be calmest in parents' arms, so get mom and dad, if it's appropriate, get them involved. Warm your hands, warm your stethoscope if possible. Be opportunistic with this exam. Use a soft voice. Smile with them. If a child is quiet, listen to the heart and lungs first. Sometimes you have to shift things around and take advantage of a quiet time or whatever. A pacifier or glove finger to suck on may quiet a crying child. Jingling your keys, all those kind of things. So moving on to toddler, ages 1 to 2. Remember, this does include the terrible twos. These little guys, they are not capable of reasoning. They have a poorly developed sense of cause and effect. Really just a handful, man. These language development is occurring rapidly. Their ability to crawl, walk, run, all of that is growing. But painful procedures on these guys may make some lasting impressions. So we want to do a good job of being honest and open about things we're going to do and talk about things and not sneak up on them with whatever we're doing. So we want to use the pediatric assessment triangle to assess the child when we talk about checking out these kids. Strategies for examining a toddler include the following. So examine a toddler in stable condition on the parent's lap. What that does is help us to avoid some separation anxiety. Also, get down to their level if possible. Talk to the child. Have a parent assist when possible. Use play and distraction when possible. Offering choices helps the child feel in control. Consider saving upsetting or painful steps for last. And then be flexible, which we talked about, that sometimes you've got to move things around in the way that you're going to do things. Now, all of these things that we're talking about are really going to be for the not sick type kids, right? If somebody's sick, they've been in a bad car accident or whatever, it's going to be probably a little bit more business-like, right? Moving on to preschool, 3 to 5. They rapidly become verbal and active, so they can understand directions. They're basically, most of them are generally able to tell you what hurts. Now, choose your words carefully. Preschoolers are very literal. Use plain language and then lots of reassurance, and just remember that fears are going to be very common with this age group. So, these guys and gals are very curious. Most of them want to cooperate, but respect their modesty by keeping them covered. Let the child participate or hold equipment that's safe. Set the limits on the behavior, though, if the child acts out of what we're going to do and what we're not going to do. School-age children, we're just blazing through this stuff, I know, but this is stuff you've done, and there's really not a lot to talk about here. So ages 6 to 12, capable of abstract thought. So these guys are starting to understand cause and effect. School is important, so is popularity issues, peer pressure, all of those things. Now, remember in this age, 6 to 12, that chronic illnesses or any type of disability or whatever, they can be a little bit self-conscious about this. So understanding of death may increase anxiety and may have their own ideas about medical care. And then talking about some physical changes, breasts will start to develop between ages 8 and 13. And then the menstrual period begins somewhere between the ages of 9 and 16, and testicles increase in the size around age 10. Really what we're talking about here for the most part is puberty, right? As well as they may be a little bit self-conscious too about some of these things. But while we're interviewing, we want to ask these kids to help describe this history and symptoms, explain steps in simple language, answering questions, offer appropriate choices, reassurance, encouragement, all of those things. Respect some modesty about them. Sometimes distractions are really good. So asking them about school, if they're hurting or has a lot of anxiety, they're anxious. Asking them about school or their pets is usually really good with these guys too. And then maybe even you're able to reward, a small child with one of these kids with something after you do a procedure. If you had something that you could give them, just a nice reward. Ages 13 to 18, adolescents. So these guys, as you are aware, can be difficult. Teens are struggling with independence as well as social and personal issues. Once secondary sexual characteristics have developed, you want to treat an adolescent as an adult. And we just talked about that, talking about puberty. So we also want to treat them as an adult when we're talking about CPR, foreign body airway obstruction, all of that stuff. That's when we really want to shift into adult, thinking. So during your assessment, address and reassure the patient. So encourage any questions, address concerns and fears. Accurate information. We've got to respect these guys' privacy. If possible, address the adolescent without a caregiver present. So especially when we're talking about sexuality, drug use, those kind of things. So if drug use or alcohol abuse or like STD or rape or one of those kind of things is part of the deal, then it may be a good idea to try to get them away from their caregiver a little bit. Oh, there we go. Now I see the word. If you remember me stuttering and stammering, you're thinking which time, but on the last video, I could not remember the word fontanelles, and there it is. I just remembered that. I was struggling with that word, talking about those sutures. So fontanelles, that's the word that I was trying to remember. So talking about these infants' head. So their heads are large relative to the rest of their bodies. Remember, they all have big noggins, and many times their noggins kind of direct them where they go. So I always kind of like to joke around that these guys, their head moves and their body follows. They just go wherever their head takes them. But an infant's head is 2/3 its adult size. Now, their body is nowhere near 2/3 of its adult size. So that tells you, a little bit about things. Large surface area means more mass relative to the rest of their body. And now, a thing to think about is this is an important factor in the incidence of head injuries, that their size. So they tend to lead with their head in a fall. So take care when positioning the airway. If we're talking about a seriously injured kid that's younger than 2, you can place a thin layer of padding under their shoulders or their upper torso to help get you a neutral position. And then seriously ill, younger than 2, you can get a folded sheet underneath their occiput to obtain a sniffing position. Those are 2 important positions, neutral and sniffing position for these age groups. Make sure we're keeping them warm. Make sure that during infancy the fontanelles are open. We're talking about the anterior and posterior fontanelles. So what this is, where, like I said, these are the area where the infant skull bones have not fused together. So that allows compression of the head during birth and then even rapid growth of the brain. And as you can imagine, if your brain was to grow right now, after everything is, your cranium is done, shifting and moving and all of that, then we'd have some real issue. That's why we have such big issues with head bleeds. So the posterior fontanelles, those should close by about 4 months, and then the anterior close by about 2 years. So these are, as I said the other day, these are important landmarks when assessing a sick or injured infant. So bulging, that suggests increased intracranial pressure, and then sunken also suggests dehydration. Talking about those fontanelles. So the neck and the airway, children have short, stubby necks, so they can be difficult to feel the carotid pulse or even see the jugular vein. That airway is much smaller than an adult airway, so it's more prone to obstruction by a few different things: foreign body inhalation, inflammation with infection, or even a disproportionately large tongue, which they have. So during the first few months of life, infants are obligate nose breathers. So keeping that in mind, nasal obstructions with mucus can result in significant respiratory distress. So since we're talking about the airway, we'll talk about the epiglottis. It's going to be long and floppy, U-shaped, it's narrow, it's difficult to visualize during intubation with this age. So, the narrowest part of the young child's airway occurs at the level of the cricoid cartilage. So, thinking about that is what it should influence your choice of your ET tubes. Below the vocal cords, rather than at the vocal cords, is what we're talking about, that narrowest part, because in adults it is at the vocal cords, but these guys are below the vocal cords. So that's why we're not using cuffed tubes, because of that narrowing that creates that natural seal. But you do have to make sure you have the appropriate size tube to create that seal. So remember some of these little points here. Number 1 is, in anybody younger than 24 months, you want to keep their nose clean with suctioning. Tracheal cartilage is softer and more collapsible, so you want to avoid that hyperextension of their neck, those kind of things. What can happen is you can have a reverse hyperflexion, and that causes some kinking of the trachea, as well as displacing the tongue posteriorly, obstructing the airway. So keep the airway clear of all secretions. Even a small amount of stuff, particulate, matter can cause obstruction. And so knowing this, we want to make sure that because their airways are so, I'm not trying to say that they're tender or whatever, but we just want to make sure that we manage their airway well. Their jaw is smaller, we need to pay more attention, and their soft tissues are delicate and very prone to swelling. So often, correct positioning can maintain the airway, and you may not even need a use of an adjunct with these. Moving on to the respiratory system. So tidal volume is slightly smaller than in adults, but metabolic oxygen demand is doubled. So that can tell you, look right there, that this, we see where these can be issues. So it's smaller than in adults, the tidal volume, what they're bringing in, but their needs are double. So, we've got to be moving good air in and out. So functional residual capacity is smaller, so they have smaller O2 reserves. Functional residual capacity, so volume of the air in the lungs following exhalation, that's also referred to as the oxygen reserve, talking about the respiratory system. So infants breathe faster than older children. Lungs can better handle oxygen exchange as the child ages. So we're talking about 30 to 60 breaths, normal for newborns. The rate for teens is closer to the adult range. Now, a higher respiratory rate and O2 demand raise the risks for effects from inhaled toxins because they're just breathing so much in. Infants use the diaphragm, not the chest muscles during inspiration. So, any pressure on the abdomen of an infant or a young child can block that diaphragm movement, which then can cause some respiratory compromise. Also, this age also experiences muscle fatigue quicker, so that can lead to respiratory failure if these kids are having to breathe so hard for long periods of time. Infants and children are highly susceptible to hypoxia because of a few different things: decreased functional residual capacity, an increased O2 demand, and then they also have easily fatigued respiratory muscles. So much of the things that we were just talking about, that's telling us right there why they're easily susceptible to hypoxia. Infants and children will develop hypoxia rapidly with apnea and ineffective bagging. So because of that, you can cause some cardiovascular collapse and even potential arrest. So use only enough pressure to achieve visible chest rise when we're talking about these kids. Now, if you need to use a larger bag if needed, our curriculum states that you have the ability to do that. But regardless, the thing is, you want to make sure that we're just looking for some visible chest rise and fall. And then we're going to look at that as being adequate. So the bag volume should have no less than 450 to 500 mils. Maintain a pediatric O2 sat greater than 94%. And take special precautions with children who have uncorrected cardiac disease. So we want to, we're talking about increased oxygenation could harm these groups. So make sure that we're not just flowing tons of O2 to these kids if they don't need it. And then clarify the baseline oxygenation rate with the parent. So find out what they are on at home per doctor's orders and what how they're maintaining. Now, cardiovascular system. Obviously, we're just doing a big review of systems and how they are different than what we've talked to up to this point. So children rely mainly on the pulse rate to maintain adequate cardiac output and compensate for decreased oxygenation. Remember, we had all those compensatory factors when talking about adults because we had systemic vascular resistance. We had, that would help increase cardiac output. We had a lot of different things, talking about blood pressure and all of that. But typically, these kids are maintaining adequate cardiac output with the pulse rate. So when you've heard about kids, you've probably heard people talk about they maintain really well, and when they're done, they're done. That's something to think about with kids. And here's part of the reason why. So they do have a limited but vigorous cardiac reserves. So they're able to maintain longer than many adults, but like I said, when they're done, they're done. So proportionately, they have a larger circulating blood volume than compared with adults. So their absolute blood volume is less, as you can imagine. Injured children can maintain blood pressure for longer periods than adults, even though they are in shock. So proportionally, the larger volume of blood loss must occur in children before hypotension develops. So that's what we're talking about. They compensate very well. So when you find a kid that's in tachycardia, especially for an unknown reason, the thing is we need to suspect shock with an infant or a child with this. Bradycardia, now a lot of times with adults, you might see people become hypoxia. They increase the cardiac rate, trying to unload more O2 and get more O2, throughout the body. But within these kids, we see bradycardia. That usually indicates severe hypoxia. So that is something that we need to manage aggressively. Now, hypotension in these kids, that is a really bad thing. That's an ominous sign for these because oftentimes it indicates impending cardiopulmonary arrest. And then signs of vasoconstriction can include a few different things: weak peripheral pulses, delayed cap refill, even some pale, cool extremities. So moving on to the heart. The heart circulation in the fetus is very different than in the newborn. So large right side forces on the ECG are normal in young infants. During the first year of life, the ECG axis and voltages shift to reflect left ventricular dominance. Remember when we talked about axis deviation, all that? That's what we're talking about right now. Cardiac output is rate dependent in infants, and we just mentioned that. So what happens is these guys have a pretty poor, really a poor ability to increase stroke volume, and that is reflected in their normal pulse rates and in their rate response to physiologic stress and hypovolemia. So mediastinum is more mobile in adults, so they have a high risk of injury to the mediastinal organs. Now, that may not be immediately evident on exam. Still have some things like cardiac tamponades, cardiac contusions, all of that. They can present much the same way, so present with muffled heart tones when we're talking about tamponade. Cardiac contusions can present with some dysrhythmias. Moving on to the nervous system. So this nervous system is continually developing throughout childhood. And one of the things to keep in mind is this neural tissue and a vasculature are very fragile. They're easily damaged and prone to bleeding from injury. So the brain and spinal cord, they're not as well protected either. The subarachnoid space is relatively smaller. So by having that, you have less cushioning effect for the brain. And then head momentum may cause bruising and damage. So the pediatric's brain requires nearly twice the cerebral blood flow as an adult's. So that makes even minor injuries significant. It increases the risk of hypoxia. So hypoxia and hypotension, as you should know, that can exacerbate head injuries. So we want to be thoughtful about that. And then the brain continues to develop rapidly after birth. And as that happens, obviously as there's more development, then the responses become more organized and purposeful. Moving on to the spinal column. In young children, the cervical spine fulcrum is higher because the head is heavier. So this fulcrum is closer to C1 and C2. So it descends to the adult level as the child develops, somewhere around C5 to C7. So an infant who sustains blunt head trauma involving acceleration, deceleration forces is at risk for a fatal high cervical spinal injury. And then school-aged children will likely sustain a lower cervical spinal injury, which could cause paralysis. Now, we're talking about some vertebral fractures. So within vertebral fractures and spinal cord injuries in young children, those things are uncommon. And I'll tell you that what happens is spinal ligaments and the joint capsules are more lax, so you get more increased mobility and cord injury in the absence of identifiable vertebral bony fracture or dislocation because of that difference. Vertebral bodies are aligned anteriorly and can slide forward, so that has the potential for cord damage with significant forward flexion. And then thoracic and lumbar spinal injuries are relatively uncommon. You can see some seatbelt associated lumbar spinal injuries, or even maybe some compression fractures due to axial loading if a child falls. But with as with all significant mechanism of injury, we want to assume a cervical spine injury and then transport with them immobilized. So the abdomen and pelvis, the abdominal organs of an infant or child, are susceptible to injury. That abdominal wall is thin, so by having that abdominal wall being thin, organs, they tend to be closer to the surface. But children have proportionately larger solid organs. They also have less subcu fat and less protective abdominal musculature. So abdominal distension in a healthy infant is usually due to two factors: weak abdominal muscles or larger solid organs. Another thing is the liver and spleen extend below the rib cage in young children, so it's less protected. Also, obviously it has a good blood supply, so with damage there, you can have some significant blood loss. The kidneys are more vulnerable to injury. They're more mobile. They're less well supported. The lower ribs, they don't shield them from injury as well. Pancreas and the duodenum are likely to be damaged in handlebar injuries. And then the organs become more proportional in size and better protected as the child grows. So they kind of grow into their organs, right, is what we're kind of saying here. So pelvic fractures are uncommon unless you have some type of high energy mechanism of injury. Typically, pelvic fractures are uncommon with this. So musculoskeletal system, reaching adult height requires active bone growth. Makes sense. Growth plates or the ossification centers of a child's bones, they're made of cartilage, they're relatively weak, they're also easily fractured. So the bones of growing children are weaker than their ligaments and tendons. That makes fractures more common than sprains. Joint dislocation without associated fractures are not common. Most growth plates will be closed by late adolescence. And then growth plate fractures can be seen with low energy MOIs. Slipped capital femoral epiphysis is a problem in the hip that affects the epiphysis of the femur. So this occurs in children and adolescents, prominently found in overweight kids. It's considered a pediatric disease, and it has a gradual onset condition unless there are signs of trauma. So the symptoms include difficulty in walking and a noticeable limp, the inability to bear weight on a limb, painful and limited normal flexion and rotation. So, we want to stabilize all sprains or strains and suspect fractures because of what we talked about before, that, that is more common than the sprains. So growth plate injuries, they can result, as you can imagine, in poor bone growth, which can have some, obviously lifelong issues. Chest and wall. Chest wall is quite thin, so you have less musculature and subcu fat to protect the ribs and the organs. The ribs are more pliable and flexible than an adult, so that can lead to significant intrathoracic injury with minimal external findings because of everything being so squishy, so pliable. Have fewer rib fractures and flail chest events than their adult counterparts. Injuries to thoracic organs may be more severe, more vulnerable to pulmonary contusions, cardiac tamponade, diaphragmatic rupture. Their lungs are prone to pneumothorax from excessive pressures, so be careful when we're doing bag mask, any positive pressure ventilation, because you have a really good chance of barotrauma if we're not paying attention. So look for signs of chest injuries with suspected chest trauma. So remember this, that a sign of a pneumo or even a hemothorax in children, those signs and symptoms are often very subtle. So you may not see things like JVD. It may be, they have a little more fat around their neck. It may make it more difficult to determine tracheal deviation. But you should be suspicious of bruising to the chest and torso in non-ambulatory children. Integumentary system. Infants and children have thinner and more elastic skin. They also have a higher body surface area weight ratio and then less subcu tissue. So these factors contribute to increased risk of injury following exposure to temperature extremes. So you have an increased risk of hypothermia, which, we should know, we should remember from ACLS, that can complicate your resuscitation efforts. Also, dehydration, when we're talking about a risk of hypothermia. Increased severity of burns. Burns that would be minor or moderate in adults are severe in children. Moving right along to metabolic differences. So limited stores of glycogen and glucose are rapidly depleted. So one thing we want to do is be suspicious of hypoglycemia. Check the blood glucose levels with lethargy or seizures or decreased activity, altered mental status, those kind of things. They are highly susceptible to hypothermia due to lowered glucose. So if they do have a low glucose, they have a little bit better chance of becoming hypothermic than otherwise. Significant hypovolemia and electrolyte derangements are more common as a result of severe vomiting and diarrhea. We talked a little bit about that. They're not going to be taking good things in, and they're getting rid of things, so a good chance of dehydration when we're talking about severe vomiting and diarrhea. And with that dehydration or hypovolemia, we also have electrolyte issues. And then, of course, we want to keep these kids warm during our transport. Parents of ill or injured children. So serious illness or injury to a child is one of the most stressful situations for caregivers. Remember, some of these parents or a caregiver, they can react with anger or fear or whatever. Remember, they're not necessarily acting out towards you. It's just this situation has messed them up. So one thing that we want to try to do is make sure that we establish a rapport with them. Because they are the source of important information and some assistance as well. And remember that these kids, and we might have to remind their caregivers or mom or dad or grandpa or grandma that they look to their parents or this caregiver when they're frightened, and they often mimic their response. So that's the time we kind of need them to, have it together and do a good job of keeping it together. So one of the things we want to make sure that we do is we try to engage and approach the caregivers in a professional manner. We don't want to talk down to them and all of that. We want to, because by having good rapport with them, we can enlist their help in caring for the child. Now we need to explain what we're doing, provide honest reassurance and support. Don't blame the parent, and then transport at least one caregiver with the child. Now, that's obviously going to be based upon your individual protocols. I've been at a place where we were not allowed to. It didn't matter if it was a baby or not, as well as other places where mom can hold the baby on the cot. It all depends upon your local stuff. So comfort and emotional parent, but remember that your first priority is the child. So don't allow mom or dad or whoever to take over and start taking your attention when baby needs your attention. So don't let a distraught or aggressive parent interfere with your care. That's one of the things that I always had a hard time with on either a sick kid or a pediatric full arrest was, I got to the point where I just didn't want mom or dad around while I was working this kid because there's just all the other things that are associated with it. But I also, on the flip side, see the benefit of having mom and dad there as a parent myself of how I would feel if I was put off. So, sometimes what I would do is tell them that, you can stay here, but if you start becoming distracting, then you're going to have to leave. And that kind of lets them know that, as long as you're not interrupting, then we're all good here. Now, you may need to enlist the help of other family members when we're talking about dealing with an emotional parent or caregiver, or even law enforcement if needed. So pediatric patient assessment, obviously this is going to differ somewhat with pediatric patients. So, you want to adapt your assessment skills to what you already have, start adapting them and start evolving these assessment skills into this age group. Use age-appropriate equipment, review your age-appropriate vital signs. Now we're talking about scene size up, so much the same way, we want to start collecting that information from dispatch, and what, for a number of reasons, what's going on to an extent. Many times we get the wrong information, but that kind of should help us kind of decide what equipment we need to take in. Maybe you work in a place that has a pediatric kit, or you just kind of piece it all together out of your other kits or whatever you have. But we want to definitely collect that information from dispatch. So the age and sex of the child, location of the scene, nature of illness or mechanism of injury, right? All that same stuff. We want to, all the same things, take appropriate standard precautions. So observe for hazards. Resist the temptation to hastily approach the patient because you know the patient is a child. We still have to maintain our standards. We still have to do our proper scene size up, all of that. One of the things, though, we talked a little bit about with adults is we want to make sure we note the child's position right then as we approach. Are they paying attention to us? You know, are they sitting in an awkward position? Are they in tripod position? You know, maybe mom or dad is holding them and they're unresponsive or whatever, but we want to pay attention to that. We also want to start looking for clues to mechanism of injury or the nature of illness. Maybe, you know, the baby is altered and we kind of take a quick glance around and you see an empty pill bottle that had some spilled pills on the table, or who knows, you know, all of those kind of things, but we want to look for clues. So when a child is unable to communicate or is unresponsive, we want to assume the mechanism of injury was significant enough to cause the head or neck injuries. So we want to immobilize spine with a cervical collar, place a pad under their head, you know, or shoulders to facilitate airway management. As I said before, when we're looking for clues, we want to note any pills, any medicine bottles, alcohol, drug paraphernalia, household chemicals as well. We also want to observe the scene or the vehicle for clues to the potential severity of any injuries. You know, so we're looking at a car seat to see if there's damage to the car seat. Looking to make sure the car seat was buckled in, and we're not going to take the time to make sure it was buckled in appropriately, but you can quickly grab it and just pull on it, and you'll know if it's buckled in or not. Other important assessments, so, you know, some of the other things that you're probably paying attention to and may not even recognize it, but, you know, we're looking around kind of the safety of the home, you know, the cleanliness of the home, general appearance of the other children in the family. So, you know, if they're all very concerned for baby, some of these other kids, or if they're, you know, just acting inappropriately and kind of weird, pay attention to that too. Of course, we want to look for the presence of any medical devices that's used for the child and any indications of parental substance abuse. And then at the back end of this, obviously we need to determine whether additional resources are necessary. So we talked about the pediatric assessment triangle. Here's what we're talking about. We talked about this kind of thing already when we talked about our sick or not sick thing that we did. But this, what we do with this is we use this to form a general impression. So this helps you form kind of that from the doorway impression and distinguish between sick and not sick patients. 3 things that we're looking for: appearance, work of breathing, and circulation. And what this kind of does, in a nutshell, is it kind of paints an accurate clinical picture of cardiopulmonary status and their LOC. Now, this is conducted prior to your ABCDE, all of that, your primary assessment. It doesn't require you to touch the patient. This is a hands-off, rapid, systematic approach to observing an ill or injured child. And what this does for us, by saying sick or not sick, it helps establish that urgency for treatment or transport. So, you know, when we say sick, we know load and go, right? Those are kind of synonymous. When we say not sick, you can kind of stay and play, right? So that's kind of what we're talking about. We're going to look at each one of them. I know we probably went into all of this already when we did sick or not sick, but it's this is a good tool, and I believe you should use this tool with every single patient. I believe you probably already do to an extent, but we're going to go through all of this. So the appearance, a really big part, often the most important factor in determining the severity of illness, the need for treatment and response to therapy. So what this does is it kind of reflects the adequacy of ventilation, oxygenation, perfusion, body homeostasis, and even your central nervous system function. So you have a mnemonic for this. You can use tickles. So I don't think, well, you see it over here, right here. You have tickles, so tone, interactiveness, consolability, look or gaze, and then speech or cry. And you can see the things to look for each one of those. You want to observe this from a distance, allowing child to interact with the caregiver. So while you're at the doorway walking in, that's when you're going to be looking at this stuff. So delay touching that patient until you've formed a good general impression, your first impression. Because here's why. If you don't know it, your touch can agitate a child. So you just walk in and you touch them and you make them mad and you get them all wound up, and now you're not able to look at any of this, right? Because consolability may not be so easy to figure out when they're screaming because you went and messed with them. So unless that child is unconscious or critically ill, take your time in assessing appearance by observation. So take your time with this mnemonic unless they are sick and it's a load and go. Then you got to move on, right? So appearance, a child with a grossly abnormal appearance requires immediate life support. So, abnormal appearance can result from numerous physiological abnormalities, and there's a number of them. I'll give you a couple. Inadequate oxygenation or even ventilation, inadequate brain perfusion, systemic abnormalities or metabolic derangements, or even acute or chronic brain injury. So a child with grossly abnormal appearance is seriously ill and requires immediate life support, interventions, and transport. So that the remainder of that PAT plus the hands-on assessment, they may help identify the cause, severity, the need for treatment. The work of breathing. Hang on 1 second here. Work of breathing. Now we're moving on to our second category. This is often a better assessment of oxygenation and ventilation status than auscultation or the respiratory rate. So what this does is it reflects the child's attempt to compensate for abnormalities in oxygenation and ventilation, because we know the body just does that. We'll increase the respiratory rate or we'll increase the depth of breath and all of that. This includes listening for abnormal airway sounds and looking for signs of increased breathing effort. Some abnormal airway sounds can be heard without a stethoscope. You guys have all probably heard wheezing. You've probably all heard rails when you've walked in someone's house that's in CHF. You might hear that rails, that fluidy sound as they're breathing. So snoring, muffled, hoarse voice, stridor, all those things can indicate obstruction at the level of oropharynx, the glottis or supraglottic structures. Now, this can result from croup or bacterial upper airway infections, a lodged foreign body, bleeding, or edema. Now, lower airway obstruction is suggested by abnormal grunting or wheezing. So hopefully when I just told you that, and you're looking at this in your book, hopefully right now, you're going to see that as probably a really good question on a test. If not for me and Gordon Cooper, for the registry. But upper and lower airway obstructions and the sounds that come with them and the things that the results from that. So those are obviously, for me, listening to that as I say it out loud, that tells me that's probably that could be a good question. So remember, I think we've talked about this, or hopefully you've already figured out, but grunting can be a form of that auto PEEP, right? You remember PEEP, positive end expiratory pressure. So what it does is by grunting or even by using PEEP, it distends the alveoli to promote maximum gas exchange. So it involves exhaling against a partially closed glottis. And I think I've mentioned it. I know in class I have. But it's a lot of times if you go and you run on those guys that are, in their mid-50s, I would say old guys, but my gosh, that's just a few years for me, so I won't say the old guys. But anywhere in your mid-50s to your 80s, most of them have a history of smoking. If you see them breathing against pursed lips, that's what we're talking about. And they're breathing out kind of pretty forceful through a very small opening in their lips. That's what they're doing, is they're creating PEEP. So it's they're opening up all the alveoli and allowing maximum gas exchange. So maximum O2, maximum waste gases, all of that to transfer and do what they do. So sometimes with kids now, this can be often mistaken for whimpering, but what this should do is alert you to moderate to severe hypoxia. Now, this is seen with pneumonia and pulmonary edema and all of that. And what it does, it reflects poor gas exchange because of fluid in the lower airway and in air sacs. Now, moving on to wheezing, that often occurs during exhalation only. Can occur during inspiration and expiration during severe asthma attacks, but usually heard by auscultation through severe obstruction may result in audible wheezing. All right, that's 45 minutes. I'm not really at a great stopping point, but I'm going to try to keep these to 45 minutes. So we'll stop here, and we're going to pick up with more work on our primary survey.